morning for our grand rounds.
Aw, awesome. Thank you so much, Katie. It's great to be back with you all this morning. So like Katie said, my name's Rachel Lusk, and I am a general outpatient pediatrician, but definitely have a special interest in working with underserved communities. And so when I finished my global health fellowship, had the opportunity to work with the refugee clinic over at Valleywise Health. And it was a really great opportunity to learn more about caring for children in our community that are refugees or children of refugee parents. And so just wanted to share some of the things that I learned along the way as far as providing clinical care for these patients. I will say it says for the outpatient pediatrician, but really, no matter where you work in medicine, you're going to be seeing these patients, and hopefully this information is really helpful to you, whether you work in the hospital or in the clinic setting. I will say, as an outpatient pediatrician, I think we have a really unique opportunity that we get to build relationships with these families over time as we're seeing them for well checks and things like that. And so I think we really have the opportunity to be a safe space for them as they're trying to navigate being in a new country and a new place. And so it's just a really unique population that we get to serve. And so hopefully can give you all some tips in providing care for these patients. So the big objectives I have for this talk, one is to be able to recognize what a refugee is. So I know when I started doing refugee care, that was something that I wasn't quite sure about what that definition was and kind of how that was different from somebody who's seeking asylum versus an immigrant. Understand that these families go through a lot of health screenings before and after they come to the US, and understanding how to access those health screenings. And then just understand the specific health considerations and barriers that those patients might face as they're navigating our health system in the US. So, as far as the definition of a refugee, this was actually set by the United Nations back in 1951, and the United Nations is the one who can designate somebody as a refugee. So, a refugee is somebody that has a well-founded fear of being persecuted for whatever reason, and so they can't stay in their home country, and they have to go somewhere else in order to be safe, basically. And the journey that these families take before we even meet them here in the United States is actually really long and tedious. This is, again, something I just wasn't aware of before I started caring for these patients. But as far as kind of the journey of a refugee, they flee their country of origin to somewhere that's relatively safe in a neighboring country. Then they have to apply to meet the definition of a refugee through the United Nations. So they submit an application to be able to be classified as a refugee so that then the United Nations can decide for each family what's the best kind of long-term solution. So there are refugees that end up going back to their home countries just depending on the situation. But basically they're trying to figure out what's going to be safest for everybody involved. The average wait for this application to be processed and for referrals to be submitted is 7 years. So I took care of a lot of families where it wasn't uncommon that families had been in refugee camps for decades. And so you can tell it's a really long process. It's not something that happens overnight. Once families are approved as refugees, and start going through the application process, looking at being resettled somewhere else, they go through extensive background checks, interviews, things like that. And then their applications are either approved or denied for being resettled somewhere else. Once they are approved, they do go through a complete medical examination, and I'll talk a little bit about what that looks like and how to access that information. And then they can get approved for being resettled in a different country and receive cultural orientation, language training based on where they're being resettled. And then it's only after that that they're actually resettled in the United States. When they come here, they are already paired with a refugee resettlement agency. That agency is in charge of helping them with navigating things, especially the first year. So housing, jobs, school for the kids, things like that. So if you are seeing a family that's more newly resettled, they should have a case manager through their resettlement agency that's helping them with a lot of things. And they can be a really great resource, especially if it's maybe a more complex medical situation or things like that. Sometimes it's good to work closely with those case managers. And I just wanted to give people an idea of kind of what a refugee camp setting is like, where families are coming from, basically, some of the families that we're seeing. So the picture on the top left is a refugee camp in Jordan, and the bottom right is a refugee camp in Kenya. So if you think about, families are living in these kind of uncertain situations for decades, and then all of a sudden kind of being thrust into living here in the United States where things work very differently. I think it's just important to keep that perspective of it's a really big change for these families. And then just to clarify, because I know sometimes these words get kind of used as meaning the same thing, but they are very different. So, someone who's seeking asylum is somebody who meets the definition of a refugee. So, left their country of origin, fearing persecution, fearing for their safety, but they are coming to the seeking admission, or they're already in the United States or at a U.S. port of entry. So, they haven't gone through that whole process that refugees have already gone through, that kind of 7-year application, things like that. And then an immigrant is anybody who's legally admitted for permanent residence in the United States. And they can come as an immigrant in a lot of different ways. Another term you might hear is an SIV, or a special immigrant visa. And this was a special program that was set up for people from Afghanistan or Iraq that worked for the US military as translators or other things like that. So for all intents and purposes, they are treated very much the same as refugees, but you might hear that term SIV that comes up when you're talking with patients sometimes. And just to give a little bit background, there is 117 million people that are forcibly displaced worldwide. A good number of those, so 68 million, are internally displaced people. So those are people that have had to flee their kind of home area, but still within their country of origin. So kind of awaiting for the situation, whatever it might be, to resolve so they can go back to where they're from. But there's about 31 million refugees, or people that meet the definition of a refugee, worldwide as of these numbers are from 2023. So when we look at those numbers, there's 31 million refugees worldwide. About 3/4 come from just 5 countries. So Afghanistan, Syria, Venezuela, Ukraine, and Sudan. And when you look at the number of refugees that were resettled in 2023, it's about 158,000. So I think another misconception I had when I was caring for these patients is that every refugee eventually gets resettled somewhere, but it's actually less than 1% of refugees get resettled and have an opportunity to kind of build their life in a new place. As far as refugee resettlement in the US, so there were 1.2 million new applications to be resettled in the US in 2023. And the US took in about 60,000 refugees. And when you look at the states with the highest numbers of refugees that are resettled, Arizona is actually in the top 5. So you will be seeing these patients kind of no matter where you work in medicine. But yeah, just really interesting to know that Arizona takes in quite a few resettled refugees. And then why this is important as a pediatrician as well is that children account for about 30% of the world's population, but about 40% of all forcibly displaced people. So they're definitely overrepresented in this population. And then just for the numbers for Arizona, looking at where refugees are coming from. So in 2024, the most common place refugees were coming from was actually Cuba. Second was the DRC, or Democratic Republic of Congo, Afghanistan, Haiti, and Burma. But as you can see, this is just kind of the top countries that Arizona receives refugees from. But when you look at the actual list, there's just dozens and dozens of countries that families are coming from. So we have an opportunity to get to meet a lot of people from just really all over the world. So now I just want to talk about some specific health considerations in these patients. So for me, like when I'm seeing a new patient in clinic that I know is a refugee family, for me, it's really important to know and think about the patient's migration history. So we know that epidemiology is really key to understanding what things they might have specific health risk factors for. And so that's a big part of when I'm first meeting a family, is just trying to understand kind of where they've come from, where they've been, because some families were originally from one place, we're in a refugee camp in another country, maybe we're in Europe for a little while. So it's every family's journey is a little bit different, and just really helpful to understand kind of where they've been, just to have a sense of what to be looking for as a clinician. So really important questions that I always ask when I'm seeing a new family is just getting to know where the child was born, where was the family living prior to coming to the U.S., when did they arrive to the U.S.? So that's really helpful to know because somebody who got here a week ago is going to have different risk factors than somebody for health things than somebody who's been here for 5 years. Also, their understanding of how to navigate our health system and our systems in general is going to be very different. And so just really important to kind of know the timeline of kind of when they arrived here. Let's just ask how long the family was in a refugee camp, any specific history of TB, malaria, parasitic infections, things like that. If the child had any known health problems while they were abroad, and then also what were the results on their overseas screening exam. So the overseas screening exam is something every refugee has before they come to the US. I will say it's not like a very super thorough exam. It's mostly to make sure that they're safe to travel and that they're not bringing any communicable diseases into the US. So definitely they're screening for tuberculosis. They make sure their immunizations are up to date. And then all refugees also receive pre-departure antiparasitics and antimalarials, just depending on what regions they're from. Um, but the nice thing is that with this exam, if the child had some more complex health needs, so example, they had a history of seizures, there should be notes from the physicians overseas of if there was any imaging done, if they were on any specific medications, things like that. So it can be really helpful to have access to this information. The family should have this information with them, but we all know that it's, they've been through a lot, and so sometimes papers and things get lost. If you're seeing refugee patients regularly, there is a system through the CDC where you can access these records called the EDN. So if you are seeing these patients on a regular basis, you can reach out to your state refugee health coordinator and they can help you get access to that system. And as somebody who was seeing a lot of patients that were refugees, I had access to the system. It was just really helpful to look at ahead of time and just see, was there anything that they were specifically concerned about with the health of this child or anything that I should be aware of. Then once refugees get to the US, the next part in their medical screening is they get what's called a domestic refugee screening exam. So they all have to have this done within 30 days of arrival. And again, really the focus is more on communicable diseases, but also just a general sense of overall health. So the screeners that are doing these exams, if they're really worried about something, will try to make sure that they have sooner follow-up with a primary care doctor. The CDC does have guidelines for this initial screening, and every state does it differently as far as who does this screening. For you all that live in Maricopa County, it's the Maricopa County Department of Public Health that will do this initial screening. For our colleagues in Tucson, it's actually Banner that does it. And so it can vary a lot between county to county. But it's really, really important that you get a copy of these records if you're seeing refugee patients. They do a lot of labs, so like a screening CBC, hepatitis B, HIV, tuberculosis screening. I mean, they just do a lot of things. And so it's just really important for us to look at those just to, A, make sure there wasn't anything abnormal that we need to follow up on, and B, just so we're not being redundant in the testing that we're doing. And then as far as helpful resources for initial screening, so the CDC actually has a whole section of their website that's just based on refugee and immigrant health. So they have a lot of information there that's really helpful. I will say it's very tedious to go through that, especially if you're, in a clinical setting, you have a short time with patients and you're just trying to get a sense of, is there anything specific I need to be thinking about or looking for in this patient? And so in that case, the website that I actually recommend is called CareRef. So CareRef was actually developed with a group of physicians and the Minnesota Department of Public Health. It's a fantastic resource for anybody who's in a clinical setting, but it really just gives you an idea of things that you need to be thinking about. So when you go to the website, you'll be able to click the button to start the CareRef tool, put in the information about where the patient is from and like their age, gender, that kind of information, and then click recommendations. And it will summarize all of the CDC recommendations of, these are the labs that you need to be thinking about. These are the things, maybe specific health considerations for that area. It's nice too because they do update it in real time if there's any specific disease outbreaks or things within that region. So, be aware that there's a measles outbreak here or, a meningitis outbreak, things like that. So it's a really, really helpful clinical tool if you're seeing these patients in clinic. And I would say that's the website that I used more than any other, especially when you're seeing patients from such a diverse set of countries. It's hard. You can't keep track of, what everybody's at risk for based on what region they're from. And so CareRef is a really great clinical tool for that. Another thing I like to let people know is that every refugee is given one of these white IOM bags when they come to the US, and they're supposed to kind of keep all their important documents in it and bring it with them to appointments. So if you see that, often their overseas exam will be in there. And so, it can just be helpful to know, like, even if you're seeing a patient in the ER, you see one of those bags, you can know, like, oh, hey, like, did you have an overseas exam? Can I see those papers just in case you want to double check anything or be able to see their overseas exam results. And then as far as access to insurance, so all refugees have Medicaid on arrival to the US as part of the refugee resettlement program. So these patients should have insurance as soon as they come to the US. They do need to obtain citizenship within 5 years of arrival to be able to keep any benefits that they're receiving. But just, I know that's a question that comes up as far as access to health insurance, but they should all be covered under Medicaid. All right, and then I'm just going to go through specific health issues and things I think about in these patients. So I always kind of like to go through a systems-based approach just to make sure I'm not missing anything, especially when I'm meeting a new family and trying to get to know the health history of a child and assess them. So I think one of the big things we always think about is infectious disease, and obviously risk factors for infectious diseases is going to vary a lot just depending on where somebody's coming from and what's endemic to where they're coming from. So things that often we think about are things like hepatitis, malaria, HIV, parasitic infections, and tuberculosis. Malaria is one I always just like to touch on just because it can be deadly if we don't recognize it, but it's so treatable. So I think it's really important to just have an idea and just have it in your mind, especially for patients that are coming from endemic regions, especially because the symptoms can be kind of nonspecific sometimes. And so we really have to have it on our differential for patients that are coming from endemic regions more recently. So it is a parasitic infection spread by mosquitoes. The common symptoms, as you can see, are almost like flu-like symptoms often. So like fever, chills, body aches. You can see jaundice and a hepatomegaly on exam, or you can also see pallor. In cerebral edema and cerebral malaria, you can see kids presenting with ataxia, altered mental status, and speech difficulty. And this is just a map of where malaria is endemic, with the red areas being the higher risk zones. And because one of the main areas that Arizona does receive refugees from is Democratic Republic of Congo, it is something that we just need to be thinking about in the back of our mind for those patients, especially when they're presenting with kind of flu-like symptoms, especially if they're more newly arrived. So luckily, refugees that come to the US should have been treated with a pre-departure antimalarial before coming. So we don't see it a ton in this population, which is great. But I do always like to remind people that anybody that came as an immigrant or someone seeking asylum will not have received antimalarials before coming, and so would be higher risk. So for me, I always would consider it in a refugee or immigrant from anyone coming from an endemic region with fever and no URI symptoms, someone with fever and pallor, or someone who has fever and is ill appearing. The symptoms can appear as soon as 7 days after exposure, but also can appear months after coming. So again, I think when I've looked it up, the CDC does recommend just kind of thinking about it in anybody that's been to an endemic area within the past 12 months, just to be on the safe side. A test is a peripheral blood smear with specific staining or a malaria PCR test, and you can always call infectious disease for further recommendations on testing and treatment if you're concerned about this. As far as parasitic infections, so the recommendations for screening is going to be different depending on what country patients are coming from. But anybody with an absolute eosinophil count greater than 400 should have follow-up to try to determine if there's a parasitic infection that's going on. The CDC has really great charts of how to follow up eosinophilia in refugee patients, and I'll show you an example of that. All refugees do receive pre-departure antiparasitics, but again, just something to kind of keep in mind, especially if you're seeing really high eosinophils on a child on their domestic screening exam. So this is an example of one of the charts from the CDC, just based on if you're seeing eosinophilia in a refugee child, kind of things to think about based on where they're coming from, lab tests to consider, and then how to follow it up. So again, the CDC is a great resource for this, so don't feel like you kind of have to reinvent the wheel. But eosinophilia, again, in someone who's a refugee is something that definitely needs to be followed up and looking for specifically for parasitic infections. And then tuberculosis is something else that we think a lot about. And actually, these patients go through a lot of screening. So on their overseas examination, all refugees are tested for tuberculosis. On their domestic refugee screening, they're tested again. So there is quite a bit of testing that goes on. So typically, as kind of outpatient pediatricians, we're not necessarily the ones making the diagnosis. One thing to know is that the IGRA or quantiferon testing is approved for kids 2 years and older. And the results are not affected by previous BCG administration. So they're typically doing the quantiferon test at the public health department, from what I've seen. When I had talked with people who do refugee care in other areas, they were starting to maybe think about using it in younger kids, but still need more data to say that it's accurate. Those with positive TB tests should have a chest x-ray looking for signs of pulmonary disease. Again, pretty much every refugee will get this on their domestic refugee screening. But if there is a positive test or any concerns, those patients really do need to be following with the public health department. And then kind of moving on to GI and nutrition. So refugee children do have a higher prevalence of malnutrition and growth retardation, which does put them at higher risk of developmental delays. So watching their growth and nutrition closely is really important, especially for us as the outpatient pediatrician, since we're seeing these patients so frequently. The CDC does recommend that all refugee children between 6 months and 5 years be prescribed a multivitamin with iron. And then just consider other micronutrient deficiencies based on diet or if there's other risk factors. From a hematology standpoint, just certain hemoglobinopathies are more common in certain parts of the world. So the thalassemias, sickle cell disease, things like that. All refugees should have a screening CBC to check for anemia. I always ask if there's any family history of blood transfusions or anemia. Sometimes families won't be able to tell you exactly what it is that might run in their family, but can tell you like, oh, yeah, older sister has to get transfusions every 3 months or something like that. And so you need to probably dig a little bit deeper there. It used to be a recommendation that refugees coming that were less than 12 months of age get a newborn screen done when they came to the US. It has not been shown to be super helpful. There's not great evidence that it's helpful. So now it's kind of plus or minus. But I would say if there's a child that you're worried about as far as growth or other concerns, it wouldn't hurt to get a newborn screen on those infants that are less than 12 months of age. Lead screening is also really important for refugees. So all children will get a lead screen as part of their domestic refugee screening. And those that are less than 6 should actually have a repeat test done in 3 to 6 months. So as an outpatient pediatrician, that's important for me to know that I need to go ahead and repeat that test in 3 to 6 months. For those younger kids, they typically don't test older adolescents unless there's a reason to. So somebody else in the house had an elevated lead level or something like that. So lead is just another thing that we just keep a close eye on in these families. And then from a GYN perspective, female genital mutilation or cutting is still practiced in many parts of the world. Um, and so when we do see patients that have had this done, it's just really important to see if they're having any complications related to it. So things like pain, bleeding, chronic urinary tract infections, things like that. Um, for those of you in Phoenix, the Valley Wise Women's Refugee Health Clinic is a great resource if you've had patients that have had this done and maybe just want to get their opinion if there's anything specific that you need to be looking out for. So I often would refer any patients that I see that have had this done in the past to them, just to not only just assess if there's any specific needs they might have now, but just to kind of have conversations about um, things for the future, especially as girls get older and kind of near maybe having children and things like that. It's kind of good for them to be plugged in with an OBGYN who's more familiar with this. As pediatricians, it's also really important for us to know that because this practice is illegal in the US, if families specifically travel to a different country to have it performed on their daughters and then come back, it's an automatic DCS referral from us. And so I think really the thing I can be honest, I know I've had colleagues that have had this situation come up. In my 4 years working as a pediatrician for refugee families, I didn't have it come up, but I think it's an important thing to be aware of that sometimes families will want to have travel for that purpose. So just discussing with them of why we would not recommend it as providers as far as the health risks and things like that. Oral health is another really big thing, especially, as primary care pediatricians, we talk about going to the dentist a lot, but you can imagine if you've lived in a refugee camp your whole life, you probably didn't have access to dental care on a regular basis. And so for me, it was always really important to just talk with families about the importance of regular kind of preventative dental care visits, seeing the dentist every 6 months and why that's important, and just helping families navigate how to access dental care if it's something that they're struggling with as well. And then mental health is a really big thing. I think as pediatricians, we know that trauma can really affect the health and well-being of our patients, our pediatric patients, obviously their parents and their families as well. And in refugees, they always talk about this triple trauma paradigm of these families have gone through a lot before coming to the US. So there's kind of this pre-flight trauma of, you were living in your home country and then suddenly there's this fearing for your life, for whatever reason it might be, having to fear for your safety. There are families where people have undergone torture in their home countries, trying to figure out how to get to a safe place, all of those things. There's the trauma of the flight itself. So trying to figure out where you're going to go to with your family, kind of leaving behind everything that you knew, all the people you knew, fear of being caught or returned. Um, these families are at really high risk of being taken advantage of in the midst of their flight through robbery, through assault, things like that. Um, and just the uncertainty about what the future is going to hold. So getting to a refugee camp and then just really not knowing, what's going to be next. Are we going to be here for 6 months? Are we going to be here for 30 years? That's a really difficult thing. And the refugee camps themselves are um, often places where there can be, crowded conditions. Women especially are at higher risk of violence in these situations. It's just a very high stress situation for everybody involved. And then there's trauma associated with kind of the post-flight or being resettled in a new country. I think sometimes we get the idea of like, well, they must be so excited they get to come to the United States and rebuild their life. But kind of thinking about the fact that it's a very different world than what they've been used to. The language is different, how you access services and navigate things. Oftentimes they don't really know anybody here, trying to like find work, get their kids in school, learn a new language, navigate things. It's a lot. It really it's so much stress on these families. And so I think it's really important that we always keep this in mind when we're seeing these families. I never ask family-specific details about things that they went through when they were abroad, because I don't want to re-traumatize anybody. Sometimes people want to share those things just because, they want to kind of get it off their chest, and hopefully we can be a safe place for them to share, and try to kind of process things and get them connected with correct resources and people that can help them with navigating those things. But again, I think it's so important to recognize that we know that trauma has so many health implications for our patients, and these patients have been through a lot in their short lives. So when you look at the statistics, refugees do have higher rates of um, mood disorders, anxiety, and post-traumatic stress disorder. The rates are even higher in those who experienced torture or violence while they were abroad. And the Center for Victims of Torture estimates that there's about 1 million refugees who survived torture who currently live in the United States. So we're seeing a lot of these families, whether it's the parents or the children, that have really been affected by their experiences before they came to the US. Um, as far as screening tools, the Refugee Health Screener is the recommended screening tool for mental health for refugees. So it's validated in those who are 14 years or older and comes in all the languages that, not all the languages, but I would say a good majority of the languages that refugees often speak. It's a great screener, so it specifically looks for signs of depression, anxiety, and signs of post-traumatic stress disorder as well. So as a as an outpatient pediatrician, when I do maybe not necessarily my first visit with the family, but like my first well check with the teenagers, I'll have them fill this out just to get a sense of if there's anything um, that shows that maybe they're higher risk of anxiety or might benefit from mental health resources. Of course, in our younger patients, sometimes um, anxiety and those other things can present, more somatically, so stomach aches, headaches, things like that. And so just kind of always keeping that in the back of our mind and just making sure we're getting families connected with mental health resources where it's needed. All right. So those are kind of the big um, things I think about as far as like kind of medical considerations as a physician. I will say, the vast majority of kids we see are healthy, doing good. I think the bigger barriers that families often have is just trying to navigate our health system. Like I said, it's so new. I always say it's like if you dropped me off in Russia and told me to like figure out how to go see a doctor and try to, pick up prescriptions and things like that. It would just be a lot because you just don't know the language or how to navigate things. And so trying to do our best to help families navigate that so it's a little bit easier for them to seek care when they need it. So possible barriers to care. So most of these families won't have a car when they're here. So trying to help them understand access to public transportation, that they do get taxis that can provide transportation to medical appointments through Medicaid. So just helping them understand those resources, and their case managers through the resettlement agency should also be helping them with kind of learning how to navigate those things. Access to language services is huge. So um, helping families understand how to make appointments, go to see the pharmacy, radiology. And for me, it's always important to help them understand kind of what their rights are, as well as having access to translation services. This would come up a lot with me when maybe parents were concerned about how their kids are doing in school, but kind of worried about going to the school and talking to the teachers. But for me, it was always important to explain, in a public school, they have to provide translators for you. So, you know, just go ask and helping with that if needed, especially if there is a child that we're more concerned about kind of their performance in school and trying to get a sense of what's going on, how do we help um, the family better communicate with the teachers, just so we make sure that child doesn't fall kind of further behind over time. And then how does the health system work? So what is primary care? How is that different from the emergency room? So a first visit, whenever I see a family, I always go through kind of the differences. Like this is the clinic, this is where we do checkups and vaccines. If your child isn't feeling well, you can we can always see them here as well. I always make sure families know how to call 911 and can repeat that number back to me if there's an emergency, just so they don't feel stranded that, suddenly somebody's not breathing and like, no, I'm not sure kind of what to do or how to access emergency services. Um, so I think, especially in that first visit, kind of going through that, explaining what we can do in the clinic versus, if your child's having trouble breathing or, something more serious, this is where the emergency room is. They're open 24/7, but really trying to help families understand the difference between kind of the different parts of our medical system. And then health literacy and education can be so variable. So, there's a lot of parents that we see that never learned how to read or write, but then there's parents that had doctoral degrees in their home countries. And so every family is different. And so it's just really important to make sure that we're meeting them where they're at and providing care in a way that's understandable. So if they are able to read, are we providing materials to them in written language that they understand? There's great resources out there. One of them is the North American Refugee Health Care Listserv, um, North American Refugee Health Conference. Um, they actually have a whole website for healthcare professionals that take care of refugees. And people have submitted different like patient education handouts and things that they have in different languages. And it's all on their website. So that's a really great resource. The CDC has different information. So about vaccines, things like that, that you can access in different languages as well. So there are a lot of great resources out there to be able to hopefully find information for families on certain medical conditions or things like that in a language, in a written language that's understandable to them. For families that maybe didn't have access to education, where the parents didn't have access to education, um, you know, I always want to make sure that I'm explaining things in a way that is understandable to them so that when they get home, they feel confident in kind of what to do. So if I'm prescribing an antibiotic, sometimes what we'll do is get a syringe in the clinic and mark it with tape and just kind of go through it with them of, so you're going to fill it up to this line, you're going to give it to them in the morning, and then do the same thing in the evening for 7 days and doing that teaching. And then I find just in general practice, but especially with these families, teach back is really important. So, for me, it's always saying, I want to make sure I explain this in a way that makes sense. And so, can you just tell me how you're going to give that medication, just so I can make sure that I explained it in a way that makes sense. So just having them kind of explain back, because oftentimes these families can be really nice, and if you say like, okay, like, do you feel comfortable giving the medicine? They'll be like, yeah, we're good. Um, but just kind of making sure that that understanding and comprehension is there. And for me as a clinician, it's just making sure that I'm doing my job of communicating in a way that's understandable for every family. So I do find that teach back is really important. And then just finding ways to just kind of meet patients where they're at as far as their health literacy and uh, um, just kind of presenting things in a way that's going to be understandable to them. Um, and then another thing that sometimes comes up is just, there's different views of health and wellness across all cultures. We see that here in the US amongst even, you know, patients that we see that aren't refugees. And so for me, just kind of always trying to get a sense, especially if I'm seeing a new family who's, especially if their child maybe has special healthcare needs or more complex healthcare needs, just getting a sense from them of kind of what their understanding of it is and that kind of a thing. And just just kind of trying to understand where people are coming from. If there's hesitancy about certain things, just trying to get a sense of kind of where they're coming from or where the hesitancy might be coming from, and just presenting, kind of our understanding as far as the medical side of things. So I know we would come across certain populations that were hesitant about the MMR vaccine. So kind of trying to understand kind of where people are coming from with their hesitancy about that. We would have certain families that would tell us, oh, you give that vaccine and then they stop talking or things like that. And so just trying to have those conversations about, kind of why we feel it's safe and important, things like that. And so, again, it's just every single family is so different. Every, you know, two families from Congo are not going to be the same as far um, as their beliefs about health and things like that. And so it's just being individualized with every family and just trying to understand kind of where they're coming from, maybe beliefs they have about health, and then just trying to work together, as a team to provide the best health care for that child. And then I think another thing that is another possible barrier to care is when we as physicians maybe aren't as familiar with immigrant and refugee health. Again, so if I don't know that this family just came from Tanzania last week and I have a kid that's febrile and that has pallor and looks anemic, and I don't think about malaria, that can be really dangerous to that child. I know a few years ago we were getting a large number of families from Afghanistan all of a sudden. Um, and it was so nice to be on a listserv with other refugee health providers who would send out webinars on things to think about, like leishmaniasis. Like, I was like, I don't even remember what that is, or, things like that. But knowing that that's endemic to that region, being able to get information about what that looks like, things to look for, things like that. I think it's just really important. And so that's one reason I like that CareRef website, is that it can just easily in a clinical setting when you don't have a ton of time, give you at least like a rundown of things like, hey, like maybe kind of think about these things as far as infectious diseases and things like that. Uh, I think it's really important just so we don't make sure that we're not missing things as we're taking care of these kids. And then this is a list of just resources that I find really helpful. So if you take one thing away from this talk today, I hope it's that CareRef is an amazing website for clinicians that are taking care of refugee patients. I think it summarizes information so well, because I know like you have a 20-minute visit and you're just like, I just need to know, make sure I'm not missing something. And, at least in outpatient peds, we get to see them over time. But again, I think it gives a great synopsis of just the things that we need to be thinking about. The CDC Immigrant and Refugee website definitely has a lot of more detailed information. So that's a great resource. The Refugee Health Screener, that mental health screening, you can just Google for that, and it's accessible for free for your patients. So if you're seeing refugee patients, that's really helpful. And then I mentioned the North American Refugee Health Conference. They have an amazing refugee health provider listserv that I think is really great to join, especially if you're interested in global health or refugee health. They do a conference every year. It kind of goes between Canada and the United States, but it's a really great way to connect with other refugee health providers. So, like I mentioned before, a couple years ago, we had a huge influx of families from Afghanistan. It was kind of sudden for all of us, and so we were all trying to figure out how to best serve those families, things that we're supposed to be looking for. And that listserv was so helpful to me as a provider, just, because providers can share questions that come up like, hey, I'm seeing a lot of this. Is anybody else seeing this? You know, or what are resources people are using for this? So it's just a really great way to connect and find that information. And then for those of you who are residents or trainees that are maybe interested in refugee health, this is a great organization to get a part of. And the conference is amazing. I'm just really incredible health providers from all over. People are doing some really, really interesting and just amazing work, just finding ways to serve this population. And so it's a great um, listserv and conference to attend if you're interested. All right. So as far as the main takeaways, I just hope that you all, things that I hope people take away as clinicians that are going to be taking care of these patients is refugee children have often had limited access to health care. So sometimes our differentials just need to be a little bit more broad in these kids. And that goes for more than just infectious diseases. Um, so, I've seen kids with genetic disorders or things like that, and they've never seen a doctor before. So you really are kind of starting from square one of trying to figure out a diagnosis and making sure they're getting connected with the correct specialist, things like that. So again, I think sometimes we forget all the screening and things that kids go through here, and just remembering that a lot of these kids haven't had access to necessarily all of that kind of preventative care or access to healthcare in general at all. Understand that refugees, they go through a lot of screening before and after they come to the US. And so it's really helpful to have access to those resources. It can save you a lot of time. So, you're not starting to do a whole lab workup on a kid that's already had, a ton of labs done, and maybe kind of the answers you're looking for are already somewhere else. So just kind of understanding how to access those records. Again, CareRef is, to me, the best, most helpful tool as a clinician in a busy clinic setting, just to make sure that you kind of know what to think about for a child based on where they're coming from. And then the last thing is just kind of recognizing that navigating a new system, health system, a new country, there's a lot of challenges that can come with that. And so I think, again, as pediatricians, we can serve as such an important kind of touch point for those families. For me, it's always really important to create a safe space where families feel safe to share kind of, whatever it is that maybe they need help with. I've had families let us know, like, hey, our air conditioning's out. And we all know in Arizona that that's a huge health hazard. And so just making sure that we're providing a safe space for families, that we can help try to connect them with local community organizations or local resources, really to promote the health and well-being of the child and the whole family. All right. And with that, we're just going to do a final question. So you are seeing a 4-year-old little girl who just arrived to Arizona as a refugee with her parents and siblings. The family is originally from the Democratic Republic of Congo, but the patient was born and has lived in a refugee camp in Tanzania for her entire life before coming to the US. You do not currently have the results of her overseas health examination or vaccination history. What specific labs should be ordered as part of her domestic refugee screening per CDC guidelines? She is reportedly previously healthy with no known family history of hepatitis. Give people a few minutes to think about that, or yeah.
Screening as well.
I was thinking F, but I couldn't remember if hepatitis C was.
Yeah. Any other thoughts? All right. So actually the answer is G. And I'll kind of go through how to try to figure that out. So again, I would use CareRep in this situation, just to put in the child. So you can put in the child's information, so that she was resettled to Arizona, originally from Tanzania, her birth date, and that you don't have the information on her overseas screening exam. And this can give you a sense of what it looks like for as far as the recommendations on CareRep. So you can see it's very succinct and then has links to the CDC website if there's more information that you need. So children arriving as refugees do typically get testing for hepatitis B. Hepatitis C is actually not universally recommended unless there's risk factors. So specifically, if they're an unaccompanied refugee minor, so those are kids that got separated from their families and are being resettled by themselves, just because you don't have a good sense of maybe what was going on before they came to the US. And then any children with risk factors, so those with HIV, a household contact with hepatitis C, or signs or symptoms of liver disease. So this child who's previously healthy, no risk factors, would not need the hepatitis C testing, but would get all the other testing. So the CBC, hepatitis B testing, lead, and TB testing. All right, and I do want to shout out the Valleywise Pediatric Refugee Clinic. I think for those of you who haven't aren't as familiar with them, it's just an incredible group of people that are providing care for refugee children over at Valleywise Health. So Dr. Shannon Barker is the physician in charge of that clinic now. Charmaine Jackson is the main nurse for that clinic. And then they have an incredible staff of cultural health navigators that are staff members that come from the most common refugee communities that they serve, that help with in-person translation during visits, but more than that, help families with navigating the health system and can connect them with community resources. So as residents, definitely take advantage when you're over at Valleywise to kind of get to know those staff members. They have a lot of knowledge and wisdom that they can share with you as far as caring for refugees. And those of you who have your continuity clinic over there, I know you've probably worked with them a lot already. But with that, I'm happy to take any questions that anybody has.
Thank you, Rachel, very much. Can you hear me okay?
Yeah, I can hear you.
Okay, good. We're using the ceiling microphones here in the Cohen Center, which are relatively new. So one question came in during the chat, and it was for a comment from Shannon Barker, and she says, hey, Rachel, the new Red Book guidelines are that we can use quantiferon gold under 2 years old.
Oh, good. That's awesome. Glad to hear it. Yeah, I know when the last time I had looked and when I was talking to people, a lot of people were starting to use it anyways, just because there's just so many false positives with the PPDs for the kids that have gotten BCG vaccination. So that's great. Thanks, Shannon.
And then everybody out in the audience, this is the simplest survey you'll ever take with a QR code. Just rate one number, and you have an optional comment box. But we appreciate, the speakers always appreciate the comments, anything you learned or took away. And then Katie here is going to facilitate the Q&A from the residents here in the room.
I don't know if anyone has any questions. I wanted to ask Dr. Lusk if there was only one thing that we could do that you think in our clinics that would help make these patients feel more comfortable, what would you recommend?
I think just really listening to people. I think and just giving them the space to kind of share and talk. I think sometimes these families are kind of so used to being rushed through things. And like I said, they've just been through a lot. And so I think it's just really important to give them space to ask questions, space to kind of, share if there's anything they want to share. So I think just being a safe space and just really listening to the things that they have to say. And really, I always, at the end of my visits, always say, like, what questions do you have for me? So just really inviting them to ask about things that, trying to make it so that they don't feel so uncomfortable that they have to hold back about things that they might be curious about. Because really it can be about anything. And I hope that they know that too. It's just, it doesn't have to be health related, but, are there other questions that they have or things that we can help with them? Just again, because I think sometimes they have their case managers from the resettlement agencies, but they're often really busy. So I think as pediatricians, often we're seeing these families maybe more than their case managers, especially if there's a lot of children in the family. And so again, I think we can just be a touch point of, if there's things that are coming up that they're really struggling with, things they need. Even for the parents, I've had parents that, will talk about, their own struggles with maybe mental health and things like that. But we know that's so important for them to have that space, because then we can connect them with resources and just make sure they're safe, the kids are safe, those kinds of things.
Thank you. Rachel, we have another question or comment here in the chat from one of our community pediatricians. He said, I wanted to plug Google Translate in a pinch whenever translation services are unavailable. It has a talk to text feature, and the text can be read via Google in their own language.
Mm-hmm. Yeah, and I think sometimes you do have to get creative. I know we've seen some languages in the clinic where there's like one translator in the whole country, and so you have to book them a week in advance. But if the kid comes in for a sick visit, it can be really challenging. And so I think we always want to be using certified interpreters whenever humanly possible. But like understanding that there's just times where it's just you have to kind of figure out what you're going to do to best serve the child that's in front of you. So yeah, no, it's definitely kind of figuring out kind of what can be the best what can kind of help you get through the visit, at least in the time being. And then sometimes too with that, we'll even like, do what we can do and then call the family back later that day if maybe we're able to get a hold of that translator just to like touch base and make sure that everything was clear, any specific questions, things like that.
And I had one question, and we just got one from one of the other chiefs. I'll read hers first. Okay. When counseling on female circumcision, if a family tells you that they plan to return to their home country, are there any legal consequences when they return? Or should we bring it up when counseling?
Yeah, so I would just let them know that it's illegal in the US, and that if they do travel for that purpose and then come back, like for me as a mandated reporter, it's an automatic DCS referral. There's a great, Dr. Krista Johnson used to be in charge of the Valley Wise Women's Health Clinic, and she wrote a great article for pediatricians and OB-GYNs about this specific topic. And so I really recommend reading hers just about kind of how to navigate those things. But I think it is important for families to know just from a legal standpoint that, if they take their daughters abroad to have that done, specifically with the purpose of having that done and come back. As somebody that's a mandated reporter, I do have to make a referral to DCS. So just making sure that they're aware of that and just making sure they're aware too that it's illegal here. Because the other thing that you worry about is families find someone who's willing to do it here, but then you worry about the safety and like cleanliness and all of that of somebody who's performing that procedure when it's not legal here in the United States. So just kind of warning families about that I think is really important as well, mostly for the safety of the child.
Thank you very much, Rachel. I think we're right at time now, so
Okay.
appreciate your coming back to Phoenix virtually, and
Thanks.
good luck in your work.
Thank you. It's great to be with you guys this morning. And definitely feel free to reach out with any other questions if they come to mind. All right.